Ladies and gentlemen, good morning. I hope you are awake and ready to listen a bit to what I have to say. But first of all, I would like to thank you from the bottom of my heart for inviting me to Pakistan. It's the first time I'm here in Pakistan. I was rather innocent in thinking about your country, I must say, because we don't get much information in the media in Europe, in Germany, where I live now. I'm actually from Germany. And so it is very interesting to see how you are and to meet you personally and talk to you. And then you see what a nice and what a prestigious country this is. So thank you very much for inviting me. And of course, thank you also very much, Professor Akram and Professor Somnia, for giving me a chance to be here. Well, today I will actually talk about the cardiometabolic disease as a global threat. Interestingly, when we look into the year 1990, lower respiratory infections were the leading cause of disease and disability in the world, followed by diarrhea, by perinatal conditions, major depression. And then only ischemic heart disease and cerebrovascular disease came in. Now, when you now project this into 2020, which is not a projection anymore, of course, then ischemic heart disease is in front. And then major depression, also very important now. Road traffic accidents, not so much here. I mean, I have seen the traffic here on the roads. It's tremendous when you come from Europe, but nothing happens, no accidents. I was so surprised. So then cerebrovascular diseases, of course. So we have these now in front, and of course, they are the global burden of the day. When we wrote the recommendations, the guidelines of the International Society of Hypertension, of course, we also devoted a chapter to ethnicity, race, and hypertension. And we just looked into different comorbidities of hypertension. Well, we come from the hypertension, but you can also come from diabetes, or you can come from thrombosis, whatever you want, and call the others comorbidities. We call the others comorbidities. But when we looked into your area, South Asian populations, Indian subcontinent, I think I can dare to get you into this, then you see that there is a risk for cardiovascular and metabolic disease, so coronary artery disease and type 2 diabetes mellitus. You know that. And I think we have many talks on that today and tomorrow. This is really the problem here, and it's increasing. And the incidence, as you know, is higher than in many other parts of the country, of the world. Now, our favorite patient, he has hypertension, he has insulin resistance and type 2 diabetes and all, dyslipidemia, abdominal obesity, albuminuria, sometimes also problem of blood clotting and so on. Well, we can call this syndrome X, which was actually defined many years ago by a professor in Dresden in Germany. He called it syndrome X, but nobody really took this as an important thing. Only when others then said, well, this is metabolic syndrome, then it became very popular. And you also know that metabolic syndrome has many definitions. Not in all countries hypertension is part of it, for instance. Not in all countries albuminuria and so on. So metabolic is kind of a flow from one disease to the other, but usually the nucleus is always with insulin resistance, with dyslipidemia and obesity. Right, and I think this is a very important study that Salim Yusuf has done some years ago. You know that he has done a lot of studies and really helped with to foster our knowledge on all these diseases and treatments. And so this was the InterHeart study, where he looked with his colleagues into the risk of acute myocardial infarction with several risk factors. And I think this is not surprising, but really something to look at. You have smoking, you have diabetes, you have hypertension, you have dyslipidemia, all the culprits that we know. And alone, they correspond to, let's say, between 2 and 4% increase of the risk. But when you take them together, 1, 2, and 3 only, smoking, diabetes, and hypertension, you are already at 16-fold. And then all the 4 together with dyslipidemia, it is even much higher, and then it's exponentially increasing when you take obesity with it and when you take psychosocial stress with it. And when you take all of them, it's an increased risk factor of more than 500. I think these are very, very impressive data. It tells us that none of these diseases comes alone, but when they are together in concert, then they enormously, exponentially increase our risk. Well, that leads us again to hypertension treatment. Let's assume we have a patient who has a blood pressure of 178/106. What would we think as doctors? Well, we treat this patient. It's too high. Blood pressure has to go down. So we treat this patient from the dark yellow area of risk, so to speak, into the green box. And in the green box below 140/90, as we still think it should be a goal for hypertension treatment, he is safe, fine, we have done our job. Unfortunately, in many cases, the patient with the same blood pressure increased to 178/106 is not in the green or in the yellow box, is in the red box that is already high risk. What happens to him? Okay, we lower blood pressure. We do the same as we did before, and we are now below 140/90, fine, but we haven't done anything to the box. It's still in red. So now we have 2 strategies, and I think we should use them both. One strategy is to be more stringent with the blood pressure decrease below 130 systolically, as is recommended now not only by the US American guidelines, but also by the ISH guidelines. And the other thing is very, very importantly, lower the risk of this patient. That is, try to combat the other risk factors, be it diabetes, be it heart problems, and so on. This is a message which I think is very important. Hypertension doesn't come alone, diabetes doesn't come alone. Usually they are connected, in many cases they are connected and need to be treated together. So, let's just go a little bit into these details of hypercholesterolemia and diabetes. I skipped the other ones because I'm really not so much an expert on obesity and thrombosis, but of course they're also very important. Hypercholesterolemia. You know that the statins actually were a breakthrough. When they came, all of a sudden we were able to treat low-density lipoprotein, LDL, down to levels that were desired by the guidelines. Right. And then shortly after that, ASCOT was done, the ASCOT study, which for the first time combined blood pressure and lipid-lowering therapy. And you see you could reduce the events by about 50% for coronary heart disease and about 55% for stroke. So really an effect if you combine treatments against hypertension and dyslipidemia. And there are also studies now taking on these patients after so and so many years, 10 years, 16 years and so, and the effect is still there. So this was is a long-lasting effect. Unfortunately, we have a problem, like with antihypertensive and other treatments. We lose the patients. We lose their obedience and adherence to the treatment, and that's what you can see here. And very similar curves you also see with hypertension treatment. So what to do? Well, today we have more ways to lower plasma LDL cholesterol. We have the statins. The statins lower the intercellular cholesterol levels by stopping the HMG-CoA reductase. So there is less cholesterol being formed. Then we have ezetimibe, which is actually used to decrease the intestinal cholesterol uptake. And quite often they're used together. And then we have the newer form of treatment, the PCSK9 inhibitors. What they do, they stop PCSK9, which then increases the LDL receptors again, stops the degradation, and just helps to take up the cholesterol from the blood into the cells again, the uptake again. So that is a very reasonable armamentarium of treatment that we have now to combat dyslipidemia. Well, now when it comes to the statin treatment, we know that we can raise statin to raise it to high levels, to let's say 80 milligram atorvastatin, but we also have to face a lot of side effects like muscular cramps, muscular ache, and so on. And interestingly, there are recent papers showing that statins may have a direct effect on the HMGA-CoA in the muscle and directly affect the production of cholesterol in the muscle, not only in the liver, in a way that was not thought about some years ago. So we really have to think about what we call side effect and what we call main effect with these statins. And quite often, the goal in high-risk patients where you want to lower the LDL below 70, or what our US-American brothers say, below 50, then you cannot reach this, even with a combination with ezetimibe. Now, the third line is then, of course, the PCSK9 inhibitors. This is a monoclonal antibody, as you probably know, evolizumab, and this actually is very, very powerful. You can either use 140 milligram in a fortnight and inject that, or you can use 420 once in a month, inject it also with a nice little pump for 5 minutes, and then you really have lowered LDL. I have seen patients now with LDL levels of below 20 with this combination. So that is very, very powerful, but it is expensive. And so it can only be a third-line therapy if, with a combination of a statin and ezetimibe, we do not actually reach our goal of lowering LDL below the levels that are recommended by the guidelines. Right, let's come to diabetes a little bit. Can we prevent it? Or if we can't really prevent it, can we at least delay the onset of diabetes? Well, this is something you know. I mean, you have all the risk factors, all the culprits, all those things, abnormal lipid, race, gender, age, family history, very important actually, family history, inflammation, hypertension, smoking, and so on. And then on the left side, you have really what leads to insulin resistance as such. And again, age and genetics, where you can't do, at present, you can't do much. But overweight and obesity. So we have some of them which are treatable and some of those factors which are non-treatable. Treatable is certainly what we can measure once things have already happened. When you have an increased insulin resistance and decreased tolerance, of course, you can treat the increased lipids, you can treat the increased blood pressure and treat the increased glucose. But that is actually treatment at a later stage when things have already happened to a certain degree. That's not what you really want. You really want another treatment. You want a preventive or preemptive treatment. And that, of course, you can do with lowering smoking or assessing smoking, physical inactivity, convert it into exercise and activity and unhealthy eating. We have heard about that quite a lot, also with respect to other diseases like liver disease. And of course, another thing what is also preventively treatable is obesity. So we have some instruments in our hands where we can prevent and not only treat once things have already happened. Now, there were some early attempts to delay the onset of diabetes mellitus, and one is the LIFE study, which was done with atenolol, a beta blocker, against losartan, an ARB, which is an angiotensin 81 receptor antagonist. And you can see from that study there was a significant reduction of new onset diabetes with losartan against atenolol. Now you can say, well, a beta blocker like atenolol is not a good comparator because beta blockers tend to increase diabetes anyway and whatever. So, but that was the first demonstration that ARBs can really do something to prevent diabetes. And then there was this meta-analysis, you may have seen that, a couple of years ago, where Elliott and Meyer actually compared different drugs that we have, the ARBs, the ACE inhibitors, calcium blockers, beta blockers, and diuretics as the reference. So you have to read it this way. If you start with placebo, 0.77, then you go down with beta blockers and diuretics. They increase new onset diabetes. And that has been beautifully shown in the ALLHEAD study in the United States. People didn't want to show that, but they showed actually that with the diuretic treatment, they increased diabetes mellitus much more than, for instance, with the calcium arm. On the other hand, we have the calcium blockers, which seem to be quite neutral in new onset diabetes. And then we have the ACE inhibitors, and even more, we have significantly more the ARBs, which prevent diabetes, which delay new onset diabetes. So with these conventional drugs, if you want, you can reach something in addition to the preemptive measures. Why is angiotensin involved there? Well, you have this insulin pathway, which is certainly known to you. You have insulin working on the insulin receptor, and then you have a cascade of intracellular events, which then lead to GLUT4 coming to the membrane and leading glucose into the cell. So that is the normal pathway. Now, when you have angiotensin, it blocks at various stages. It blocks siRAs and PI3K. So you have a disruption of this normal pathway of insulin to get the glucose into the cell. Now, when you give a sartan, an ARB, then of course you block angiotensin via the AT1 receptor, and you have reinstalled at least this part that angiotensin hampered in the insulin pathway. So ACE inhibitors reduce angiotensin, as we know. And they can actually do the same as we have just seen, and you can see that in the pancreas, muscle, and fat. But the ARBs do it also by directly interfering, by directly blocking excuse me, the AT1 receptor. The ACE inhibitors have the bradykinin increase and the NO stimulation, which is helpful in this respect. And the ARBs have the adipose tissue remodeling and the PPAR gamma modulation. What is that? What is PPAR gamma modulation? Well, we spent a lot of work on that. As you can see, in yellow is from another group from San Francisco, but all the other papers we did in those years. And angiotensin working on the AT1 or the other receptor, the AT2 receptor, I will talk about this later on. Angiotensin does something. And when you block this, you actually help to be antihypertensive, anti-inflammatory, anti-atherosclerotic, and anti-diabetes. So all that happens when you block the AT1 receptor. Not extensively, but to a certain degree. Now, there comes now something which is special. Some of the ARBs, like telmisartan, but also one of the metabolites of losartan, they have a special propensity to go through the cell membrane, penetrate also through the, nuclear membrane, and then hit the nucleus, so to speak, and hit a combination of proteins that are put together there on the nucleus, and the PPARs are part of that. Now, when this happens, there is another pathway to be anti-diabetic and all the other things. So there are actually two pathways. One of them, all ARBs are doing it. They actually reduce, the diabetogenic effects. And the other pathway is some of them do it, they go into the cell as transcription factors with PPAR gamma combined and do the same. So you can really from both sides help the situation. We did a clinical study actually with patients, obese and hypertensive, and looked whether we could actually increase genes that are stimulated by PPAR gamma with telmisartan and ARB. And if we used 80 milligrams of telmisartan, one of these genes, CD36, was increase, but that was not really significant in the blood cells of these patients. But when we used a high dose of telmisartan 160, that was a significant increase. So that was the first time that we could show clinically that giving high dose of an ARB would actually increase pipa gamma genes that we could measure in the blood cells of our patients. So there is a mechanism. Well, this has been disputed. People have said, well, this is there, yes, we agree, but is it really clinically relevant? Well, that's something we don't really know, but we hope it is, and hopefully future will tell. So we have anti-diabetogenic effects, antiproteinuric and so on, also others that go beyond the blood pressure reductions when we talk about inhibitors of the renin-angiotensin system. Now, of course, a newer development is the SGLT2 inhibitors. And they have an interesting new mechanism of action, as we all know. They attack the S1 segment of the proximal tubule, where you have about 90% of renal glucose reabsorption and also sodium reabsorption. And by attacking this, by blocking this, then you lose sodium and glucose in the urine. A very nice mechanism of action, because you have then a handle on both. And you know that in the EMPA-REG outcome trial, in diabetic patients, there was a significant decrease in death from cardiovascular causes, but also these drugs can reduce blood pressure. Not as much as, let's say, a calcium antagonist, but they contribute to a reduction of blood pressure, and that's what you can see here. Of course, they reduce sodium. They act as a diuretic. And more recently, there is a study, a meta-analysis by Vaduganathan, and they have shown that in patients with heart failure, in a meta-analysis, the SGLT2 inhibitors reduce the risk of cardiovascular death and hospitalization for heart failure in a broad range of patients with heart failure, supporting their role as foundational therapy for heart failure. That's absolutely new. And what is also very new and promising, irrespective of ejection fraction or care setting. You know, we always had the problem with patients with preserved ejection fractions. So what to do with them? There is fibrosis, there is a thickening of the ventricle. What can we do there to get them back into normal heart function, even if they have a preserved ejection fraction? And this seems to be a way to get out of this dilemma. I skipped this. This is a not so good to see a scheme of how these SGLT2 inhibition works, but it's on both sides. It's on the glucose side and it's on the sodium side. And obviously, this has a beneficial effect on many things, on many organizational things in the body. We have these 3 or 4 on the market, as you know, and that's really great. That's new. That is an advantage. But, of course, in most cases in pharmacology, what works has also side effects. And here we have some side effects. We have genital urinary tract infections, quite severe at times. We have reduced bone density. We have dehydration in patients, hypotension. So there is really a broad range of side effects that we have to consider with these drugs, and we have to use them carefully in our patients. Well, the strategies of cardiovascular drug development in the past, as you see, were like this. Single attack, antihypertensive, antidiabetic, lipid-lowering, antithrombotic. Then the current developments go more for combinations. They go, for instance, for antidiabetic and lipid-lowering, or what we have just seen, lipid-lowering antihypertensive in the ASCOT study with the statin, or antihypertensive and antidiabetic, as we have now with the SGLT2 inhibitors, or antihypertensive, anti-inflammatory, and organ protective. Some of these things can already be done by existing drugs, like the ARBs, ACE inhibitors to a certain degree, and also by SGLT2, for instance. But that's certainly not enough. And the future, how is the future then? The future is something, I think, very different. When we worked on the angiotensin 82 receptor, and I will tell you the story in the next session, when we worked on that, we came across an idea saying, well, this receptor agonist for 82 works in so many fields, on so many things. It works on neurodegeneration, on inflammation, on proliferation, endothelial dysfunction, fibrosis. And this is actually overlapping in so many organ systems, like the CNS, like skin, metabolism, kidney, heart, and vessels, and lungs. So there must be an undercurrent. There must be something where we could develop drugs into which are not only antihypertensive, antidiabetics, and so on. And this will be actually the future, of course, besides genetics and precision medicine that we have heard so beautifully last night. Finally, and this is my last slides, I will show you something which gives me to think a lot. This was a study published in the New England Journal a couple of years ago about the genetic risk, adherence to a healthy lifestyle, and coronary disease. Yeah, genetic risk and healthy lifestyle. Those were the components here. The authors took several studies together, Arik and so on, combined them, and then they looked into low, middle, and high genetic risk. Now, this is the plate for low genetic risk. And you see, if you have a favorable lifestyle and you have a low genetic risk for cardiovascular metabolic disease, then you are fine off, you are just in the line, so to speak. When you have an intermediate lifestyle, I don't know what is intermediate, and you have an unfavorable lifestyle, eating too much, no exercise, smoking, alcohol, whatever, and then you're really on the right-hand side significantly. So even with a low genetic risk and an unfavorable lifestyle, you actually increase cardiovascular coronary events in this case. Now we come to the intermediate genetic risk. It looks a bit the same, only it's all shifted to the right. Even with a favorable lifestyle, if you have an intermediate genetic risk, you're already on the right side. And of course, even more so if your lifestyle is unfavorable. And now it comes to what really bothers me a lot, and this is if you have a high genetic risk and you do whatever you can do to your lifestyle. You don't drink, you exercise, you don't smoke, you sleep a lot, I don't know what, yeah? And still you are significantly in the high risk of a coronary event. This is what bothers me a lot because it tells us how much genetics play a role in all these fields. So what we can do, of course, when our genetic risk is low, we should adopt a good lifestyle. And even when it's high, we have a little chance to do better than with an unfavorable lifestyle. So it would be very important to know the genetic profile of our patients much better than we do at the present time, to be more active, more stringent with the therapy. And with this, I would like to conclude, and I thank you very much for your attention.
Thank you so much, Professor Ungar, for such an enlightening talk. Next, we have with us Dr. Umar Farooq, who is an associate professor of medicine, a distinguished nephrologist at the Penn State University, United States. He is associate chief medical officer at the Penn